I was just saying lots of wonderful things about you, and you're miserable.
We'll repeat.
But in short, I was basically saying, fantastic to see you again, and thank you so much for spending time out of your unbelievably busy program. I was just pointing out how you can't really look at any media at the moment without seeing very sage words coming from you, and obviously that we're delighted that you're one of our friends, and we've got you for the next half an hour. So thank you, and I'll hand over to you if that's all right.
Thank you, Professor Shannon, and thank you for inviting me to speak today at such an important and globally focused event. Action on Pre-eclampsia is the UK charity for women who've lived experience of pre-eclampsia, and it's the voice of those women in research, in campaigning, and it supports the training of thousands of midwives each year. So it really is a pleasure to be with you. And you talked about some of the things that I've been saying in the media. For those people who aren't aware, I'm the Minister for Equalities. I'm also a Treasury Minister, and I'm responsible for work to understand why COVID-19 has had such a disproportionate impact on ethnic minority people. And I'm also the lead minister for the new Commission on Race and Ethnic Disparities, which is examining all aspects of inequality in the UK. So the RDU, who have been supporting me in some of the work I've been looking into on maternal mortality, are also working on that commission. So because maternal health fits into my work on COVID-19 disparities today, I thought I'd share with you what I've been doing in my role to address these issues, and also, while I'm with you, just learn more about how to target action to tackle pre-eclampsia to protect women and their babies. This year, I returned from maternity leave after having my third child, so this is a topic that's very, very close to my heart. The UK is one of the safest places in the world to give birth, and clinicians manage pre-eclampsia well. They seek care seeking care before and throughout pregnancy is important. And we want all women to have the access and confidence in this care that the NHS provides, particularly in a pandemic when people are more anxious. Although maternal deaths are fortunately very rare, behind these tragic statistics, there are devastating consequences for families and children. So it's vital that we tackle this complex and concerning issue. We still lose over 1,000 babies per year to pre-eclampsia, and that remains too high. We also know that ethnic minority women and women from deprived areas have a disproportionately higher risk of poor maternal health outcomes. So for this reason, I co-hosted a roundtable on maternal mortality rates for ethnic minority women with my colleague Nadine Dorries, who's a health minister, about a couple of months ago in September. And we heard expert evidence and listened to recommendations from top academics, frontline midwives, healthcare professionals, all with the goal of developing joint solutions to benefit pregnant women and their babies. So I'd like to share some of my key takeaways from the event, particularly regarding what lies behind the 5 times more statistic. We need to drill down on the facts and evidence. The main reason driving these disparities is underlying health conditions. That's what we learned from the presentations. And we also need to debunk the myth that all complications and fatalities are due to childbirth, when it's health conditions like heart disease, diabetes, mental health. They largely explain these disparities, but they come out while women are pregnant. So given these clear findings on comorbidities, we want to and need to shift the conversation beyond just the mortality to better support maternal health more generally throughout pregnancy and the pre-pregnancy period, so that our actions can benefit more women. There's no point in battling obesity, smoking, and other risk factors when women are already pregnant. By that time, it's too late. Antenatal appointments are crucial for detecting conditions like pre-eclampsia, as I'm sure so many of you know, heart disease and hypertension as well, which I suffer from, and factors such as childcare, stigma surrounding miscarriage, discomfort with male doctors, myths surrounding pregnancy. All these things can prevent ethnic minority women from presenting. Regular checks and good observations save lives. NHS England, through the Accelerated Access Programme, has provided funding for placental growth factor testing, which is so important in detecting the likelihood of a woman developing pre-eclampsia. So I want to hear your experiences of using it. I know it's not available in devolved administrations. This may be something that we need to address. On top of these barriers, women may have faced pre-COVID, there is a real risk that the 5 times more statistic could be having a scaremongering effect, adding to women's fear of presenting in hospital during the pandemic. So I'm very conscious that we need to be careful about how we communicate the issue to women. We want to avoid misleading Black women, for instance, into thinking that giving birth is unsafe. It is safe. We need to reassure them that these numbers are still very small, while emphasizing the importance of presenting early, even during the pandemic. So as a Black woman and a mother of 3, I bring a unique perspective to my role as Equalities Minister. I'm one of those people for whom pregnancy is an ordeal. Every bad thing that can happen in pregnancy, almost everything that people complain about is something that I feel like I experienced, except I think probably a swollen feet. Whether it's the pregnancy sickness, which went on right till 35 weeks, to headaches, feeling fatigued, all sorts of odd and mysterious ailments that seem to just be related to pregnancy. I seem to have a whole swathe of them. I think I also needed crutches towards the end because I'd had something go wrong with the nerve or something like that. So I don't enjoy, much as I love children, I don't enjoy being pregnant. But what I can say is that I'm very lucky to have had such great healthcare. And in fact, it was Professor Shannon and Professor Lucy Chappell who both provided me with excellent care while I was at St. Thomas Hospital. I don't know if they mentioned that, but I did have a very scary experience right at the beginning of my first pregnancy when I was at King's. And luckily, I had been attending my appointment. So it was at my 20-week appointment. There was a researcher who wanted to carry out I think it was a cervical scan or something similar. And she noticed that my cervix had shortened, and I think it was, I remember, 3 millimeters. I wasn't allowed to leave the hospital, and I almost lost the baby. I was given an emergency cerclage. I felt very ill, probably from the stress of it all. And I shudder to think what would have happened had I not turned up for my 20-week appointment. I also know what it was like having so many questions to ask of doctors, not knowing what to do, but thankfully being in a position where I was able to communicate with the specialists, with my consultants, in terms of what was going on with my care. And I do recognize that that is not always the typical experience of many ethnic minority women. I am someone who has a very high level of education. I'm in a job where there's a high status attached to it. I don't feel, my parents were doctors, so I don't feel intimidated speaking to medical professionals. I know that this is not the case for everyone else, and trying to make sure that everyone has the confidence to do some of the things that I was able to do, I think will go some way to addressing some of the issues around maternal health more broadly. And secondly, and certainly the second time and third time that I had my children when I was based at St. Thomas, being able to talk to Professor Shannon and Professor Chappell and the wonderful care that I received there was amazing. And I will never stop praising you for everything that you did for me, including my painful surgeries. So my experiences challenge the narrative we hear in the media. I want to make sure that we're also talking about the successes and the good work we've done so far, not just what is going wrong, because I think it's important that people get a sense of perspective about the scale of the problem and the things that we need to do to tackle it. More broadly, the government is committed to levelling up, as I'm sure you've heard the Prime Minister or other ministers say. We know that there is still deep-seated inequality in this country, and we are determined to address it. Our National Health Service has launched a new phase of its Help Us Help You campaign that focuses on maternity services. And this campaign reminds pregnant women about the importance of attending checkups, contacting their midwife or maternity team when something doesn't feel right, and reassures them that the NHS is here to see them safely. And I do want to emphasize that this isn't just, I'm not the only person for whom policy is partly informed by personal experience. So many ministers and MPs who speak in Parliament, we all use the NHS. We all have personal experiences of loss. MPs speak about baby loss and sepsis are just 2 examples of campaigns that I have seen. And we do want to work with the health service to make sure that we get the very best for the country. So going back to COVID-19, and given that it has fundamentally changed the way that women have been able to access maternity services, the National Maternity Safety Champion and the Chief Midwifery Officer for England gave a 4-point plan for all maternity services in England to follow. And that includes increasing support for at-risk pregnant women, proportionately tailoring communications to reassure ethnic minority women, ensuring that hospitals discuss vitamin supplements such as vitamin D, which I had to take, for example, and nutrition in pregnancy with all women, and ensuring that all providers record ethnicity on maternity information systems. We've also revised guidance this September so that partners are able to attend maternity units for appointments and births. As a constituency MP, that was something that quite a few constituents wrote to me about, and I'm glad that we were able to make this change. NHS England is acting to drive down maternal mortality statistics through the 2024 long-term plan, and this should ensure ethnic minority women are given continuity of care, and at-risk women are seen by multidisciplinary teams. We've heard success stories directly from women service users who sit on their local NHS Maternity Voices Partnerships, advisory committees, the MVPs, and 136 MVPs operate throughout England alone. And this is an excellent example of an initiative in which women can influence the direction of travel of maternal care to better suit their needs. As much as possible, we want people to be in control of their healthcare. The government can help by shining a light on these issues and providing funding, but we can't fix everything. Women know their bodies, they know what's normal for them, and if things aren't right, they need to get those things checked out. The health service can't second guess what's going on, and we need to break down the barriers to ensure all women know that it is okay and important to access healthcare even in the pandemic. So we want to look within the health profession for solutions to rectify issues and work with experts to find ways for individuals to take more control and be empowered to take steps to improve their health. So thank you very much for giving me the opportunity to speak to you about my own personal experience and what the government's doing. And with this in mind, if we have time, I would like to put some questions to pre-eclampsia experts and maybe hear their recommendations at some point. Thank you very much.